My name's Catherine, and I'm a Doctor of Experimental Cancer Medicine at the University of Southampton. And I'm just going to speak really briefly about my role in cancer research, and then I'm going to be answering some questions all about where current cancer research is going. Now, my journey to becoming a cancer researcher hasn't been as typical as most people tend to assume. When I was a child, the idea of being a scientist seemed pretty cool according to cartoons and movies, but secondary school science wasn't always the most inspiring thing to me, so I wasn't really sure what I wanted to do. At the start of year 10, when I was 14, I suddenly became really unwell and I was rushed into hospital by ambulance to Southampton General. And after weeks of relentless testing, I was eventually diagnosed with acute myeloid leukemia. After the initial chaos of the first few days of diagnosis, my consultant started to notice that my reaction was very different to other teenagers my age. Whilst most people tend to ask, why me? I was asking, how me? How is it that a healthy 14-year-old girl who hasn't got any family history of any cancer, who hasn't smoked, who hasn't done anything wrong, how do they get leukemia? Where does it come from? What even is cancer? What's chemotherapy? How does it all work? I would sit with my doctors and they were amazing. They would answer all of my questions as best they could, but there would always come this point in the conversation where the answer would become, nobody knows. That's what research is trying to find out. My consultant once took me into her lab and she showed me my blood under a microscope and compared it to healthy blood, so I could see my cancer for myself. And I came away from that feeling so much more at peace with my situation. I understood the science of what was happening to me and why I felt the way I did. And I also remember thinking I'd quite like the idea of working in a lab one day instead of an office. In the same week that I was diagnosed, another 14-year-old girl was also diagnosed with the same leukemia as me. Naturally, our families became friends as we both started the same treatment regime at the same time. But within weeks, it became evident that there was nothing that could be done for her. Whilst the chemotherapy put my leukemia straight into remission, our consultant said that they might as well have just given her a glass of water for all the difference it made. By the time I came to start my second round of chemotherapy, she had already been sent away to die. This left me with a very new question. Why is it that two people with the same disease and seemingly identical circumstances can have the same treatment but respond so differently? What was different about me? Why was I the one that was allowed to survive? It was another question which nobody could answer, and I realised if I was ever going to get answers, I would have to go out and find them for myself. After I returned to school, I managed to scrape together a few GCSEs, but the leukemia suddenly returned with a vengeance when I was 17. My only available option now was a bone marrow transplant, a procedure which until that point I had never known anybody else survive. No one in my family was a match for me, but when we did eventually find a donor, I had to sign the consent form to go ahead with the procedure. This was the first time in all of my treatment where I was agreeing to something which would unavoidably cause life-changing permanent damage. It would make me infertile. It would also cause permanent organ damage, which would leave me taking medication for the rest of my life. And I would require continuous monitoring for the rest of my life in order to catch any new cancers or new diseases that would inevitably arise from the almost lethal dose of chemotherapy and radiotherapy. I remember being told before I signed the form that there was a 20% chance that the chemotherapy, because the chemotherapy was so toxic, there was a 20% chance it would kill me anyway. It would just cause liver and kidney failure. But nevertheless, I signed the consent form knowing that this was my only opportunity to try and survive. Doing cancer research, whilst having first-hand experience of the flaws in current therapies, is a brilliant motivator. My PhD focused on head and neck cancer, which is a cancer of the mouth, nose and throat mucosa. It's the fifth biggest cause of cancer deaths in the world, and the tumours of this cancer develop in people's faces. The survival rate hasn't changed for decades. The survival rate is only 50%. And more worryingly, the number of people getting this cancer has absolutely skyrocketed in recent years. More upsettingly, the only real treatment that we have for this cancer is brutal, life-changing surgery. At best, the surgical removal of these tumours can leave people with visible scarring and some nerve damage in their face. But at worst, it can leave people blind, unable to speak, unable to ever eat or drink again. Quality of life after cancer for these people can be utterly abysmal. And you might only be halfway through your life when you get diagnosed. Cancer patients shouldn't have to make these choices. And the moment of being told you have cancer, you will agree to almost anything to try and survive. But in the years after your treatment, especially if you have your cancer young and you just want to be normal, constantly dealing with the consequences of your long-gone cancer can have a devastating psychological impact. And what really frustrates me about this is that these side effects aren't caused by the cancer. The cancer is gone. But it's the treatment that we give to people that causes this damage. I think it's something that almost all cancer patients experience to some extent, and it's a concept which I champion at every opportunity. Cancer patients shouldn't have to choose survival at the expense of being able to live. It's something which I myself was reminded of a couple of years ago when I was diagnosed with a really mild chronic form of skin cancer. And it has specifically been caused by the irradiation that I had in the run-up to my transplant. Now, whilst this new cancer poses absolutely no threat to my life and is really easily dealt with by regular surgery, hearing that I had cancer again for the third time in 12 years and that it had been caused by my previous cancer treatment had a huge impact on me. So, what are we even doing in research to try and make cancer treatment more effective, but also less damaging to people long term? The Experimental Cancer Medicine Centre that I work for in Southampton is one of 18 that CRUK funds. And currently, we are running 127 clinical trials in Southampton alone, of which I am the lead scientist for just a handful. One of the things that all of our trials have in common is that they are first-in-human clinical trials of new immunotherapies, or new combinations of existing immunotherapies. An immunotherapy is a treatment which uses the idea that rather than attacking your cancer with chemicals, we can teach your immune system to attack your cancer for yourself. One of the hallmarks of cancer is that it's able to evade attack by your immune system, which otherwise is normally brilliant at finding and destroying any threat. But because your cancer is made of you, and because it has many ways of tricking your immune system, your body allows it to persist. That being said, your immune system is not blind to your cancer. When we look inside of tumours, we can see that they're absolutely packed full of immune cells of every kind. Your body is more than aware of the damage that the cancer is doing. But the immune cells are failing to attack. Why is this? This is a huge focus of today's cancer research, because if we can work out the reasons why your immune system is being switched off, then we can create new treatments which switch it back on. And this is not theoretical. This is already being done. It's already a standard part of treatment for some cancers, and we are working to try and get it a standard part of all cancer treatments now. The money that you raise for Cancer Research UK gives them the ability to fund as many projects and clinical trials as possible, and it trains more people like me to become scientists. My hope for my career is that I'll be able to help change clinical practice through clinical trials and make treatment for cancer more effective and less damaging long term. We need to greatly improve the quality of life for patients after cancer, because if more people are going to be surviving, this is going to become more of an issue. But I can't do any of this by myself. The world-leading cancer research that CRUK funds can only continue if public support and fundraising is there to help us, with every person's role being absolutely essential to beating cancer sooner. So thank you so much for listening to my story.